And within the Long-Term Care Act and responsive behaviors, there is a number of legislative parts of it that identifies that there is need for written protocols, assessment, reassessment, written strategies to prevent and minimize and respond. And I would suggest to you that we're on a new level of looking at behaviors. It's not just the behavior. We need to look before what caused the behavior and prevent it, and what happens afterwards to prevent any disability. Joel Sadavoy, who used to be the president, I guess is past president of the International Psychogeriatric Association, on the website is I feel is a really nice article that really characterizes the kind of characteristics of the individuals who have complexity, chronicity, changes, and the context. And when we look at behavioral issues, it's going to be important to understand that complexity, to understand that chronicity, and to understand how it's different in different settings. And it's probably, as we think through moving forward in Ontario, it's probably a useful document to focus in on. We're in 18th century healthcare. I started out with that process. We built a system that essentially waited for one of you to get sick, get yourself to the hospital. I'd poke you in the belly. I'd identify that you had appendicitis. I'd yank you up to the surgery. You'd never want me to do surgery, I'll tell you. But anyways, up to the surgical suite, take your appendix out, and send you on your way. That doesn't work. That doesn't work for chronic conditions. It's not going to work for chronic conditions. And one of the difficulties we have is, of course, we've built up this system that certainly is separated. So how do we, in the long-term care system, develop a system that's integrated, not a system that's siloed? And how do we deal with the white spaces that are between our healthcare system in a meaningful kind of way? This is self-management at its best. Sorry, but I'm the only one on duty today. Did you know that we're broke here in Ontario? And I think one of the things that's critically important is we need, there's a sign above, I think it's one of the universities it's Oxford, I think, in England, that says, we have no more money, now we must think. We have no more money, now we must think. So we're in a situation, I think, at this point in time that we have an opportunity to develop a platform for moving forward, and then to reinvest and invest. And I'd suggest that that's where we're at in the health service delivery system, at least for the next couple of years. So I just want to turn a little bit to the behavioral support system project. I would encourage you to go to the website, and there's a number of, and I'll give it to you at the end, there is a great opportunity for exchanging some of the emerging prototype practices. The frameworks that I'm going to talk about are in there, and there's some other material that is certainly important, and I think will help frame the way we move forward. We are, Ontario is a leader in behavioral support systems. There is a national initiative that's undertaking, and the work that's been done here and that I'm just going to scan over has really been acting as a foundation for moving things across Canada. So the project itself aims to improve, and I'll come to the population in a minute, older adults with complex and responsive behaviors associated with cognitive impairment due to complex mental health, addictions, dementia, or other neurological conditions, and their caregivers. So we're talking more on a functional process. Have you, in long-term care, ever got an initiative in incontinence, an initiative in dementia, initiative in stroke, initiative in, 6 or 7 more? We have initiatives for diseases, not for people. And I think one of the things that we need to do in this one is to how do we galvanize those initiatives and that wisdom together, because it's those individuals that usually present with behavioral challenges. Again, the focus here is not only in long-term care homes, but across sectors. And the first phase of the project is just about to be completed. The draft report has been put together, and we're just submitting this to the ministry for consideration. Once the report is finalized, it'll be on that website available for people. Okay, project overview. This seems like a history of the last 25 years, I think, in terms of moving forward. I'm not going to spend too much time in regards to this, but essentially just to give credit to a lot of people that are probably in this room and to move forward, that there has been a lot of activity before trying to move this piece forward. And there's been a number of individuals that have identified and given of their time to think through, to share their collective wisdom in terms of where we move. So what's the BSS project? Well, phase one has been trying to take a look, not trying to, it has, laid a foundation. And the second phase that we will be into will be looking at a demonstration or testing of that framework in the field. And I would suggest to you that that's what's kind of nice about this. This isn't policy coming from the top down, nor is it practice-based, not influencing policy. But the idea and the concept that has been supported is to begin to draw together the collective wisdom and knowledge and think about a framework to begin with, test it in the field, and then have that enriched to move forward. The individuals that have been part of this, the perspectives have been wonderful. We've had great collaboration from the Alzheimer's Society of Ontario, and the stories, the insights, the experiences from caregivers and individuals has informed the practice. Over 200 people in various LINs have been identified and have undergone conversations to identify what can we move forward with and how can we do it now. And the other focus has been in a rapid literature review. The inventory of projects has also helped us, an advisory panel. And we've also had conversations which have been really helpful with other groups to try to understand what we can learn from them, what's unique for other populations, but what's generic in terms of cross-learning as supporting other populations that have behavioral challenges. So we've talked a little bit about in terms of it's important. Well, what about the target population? And I'll just identify the reason that we focused in on this was as a beginning process. And essentially, the key issues here are responsive behavior. The second key issue is cognitive impairment. The third is aging. And the fourth is due to number of causes. And again, this is a first step, and we're trying to take a look at how we can pilot for other populations as we move forward. The principles are focused particularly on person and caregiver-directed care as the overarching principle. David mentioned behavioural communication, and there's been identification of some of the things that need to guide and drive the process in terms of moving forward with a system of care. The model that has been suggested is eloquent in its simplicity, and it basically has three components to it. The first pillar is identifying a process by which we can change from a sectoral system to more of a systems approach, whether that means a NIDIS at the LIN and the province, some sort of regional coordinating group that's there, but an overseer that's not looking at sector development, but is looking at systems development. And embedded within that, what we've also heard is ideas about continuous quality improvement, to not wait for the next 10 years of planning, but to identify through that sector collaboration issues that arise in making changes as one moves forward. The second pillar is really focusing in on galvanizing and dealing with the transitional spaces that are there as well, both internally and between organizations, with a focus on interdisciplinary but also intersectoral collaborative arrangements. And the third is how do we inform those in a meaningful way, both for the person, the healthcare system, as well as the providers through knowledge translation, as well as continuous quality improvement. And I would recognize at this point the Ontario Quality Health Council has been extremely helpful to us in terms of guiding, assisting, and moving forward.